So, good evening, everyone. I'm Karan Sharma, and on behalf of FTC, the makers of Bitcofall, I welcome you all to the 14th episode of Sunday 9 p.m. show of Iron Talks. Here on Iron Talks, we have so far discussed a wide range of topics like anemia in children, anemia in pregnancy, anemia in oncology, nephrology, endocrinology, etc. And we've come to learn that despite being such a minuscule metal in the body, it has a pivotal role in a person's well being. Having said that, let me call upon stage the expert himself, Dr. Sanjay Kalra. Dr. Sanjay Kalra has done his endocrinology from the prestigious Ames Institute from New Delhi. Sir, very good evening and a warm welcome.
Thank you, Karan, and good evening to everybody who is logged in. We are continuing with our series of iron talks, and we've already begun getting questions and comments regarding the topic. So that tells us the strength of this tiny element of iron. And today we have a very special guest for us, a teacher of teachers, someone that the entire country respects. So it's a matter of pride actually for me, pride and privilege both, to be able to introduce Professor Saple from Mumbai. He has taught at the prestigious JJ Medical College, JJ Hospitals and Medical College, and now he works at some of the leading hospitals in Mumbai, providing services in dermatology. His patients are not limited to Mumbai or to Maharashtra or to India. He gets patients from across the world actually who come seeking his expertise. Professor Saple, sir, warm welcome.
Okay. Thank you, Sanjay ji. I think today's topic is anemia in skin and hair. Of course, you are conducting many programs. You must be conducting with the various faculties. And today we are going to talk about the skin and hair. So can I have my slides? Yeah. First, let me thanks FDC, Basuji, Karan Sharma, and of course Sanjay ji for introducing me. Talking about the anemia, anemia is a very important subject, and not only important, and each and every life you must have come across either your relatives, friends, or somebody known to you has anemia, because anemia is a very important. When we were studying, when we were students, I'm talking about that 73, 72, anemia was very common. But now with a lot of information, lot of technology, lot of literature, anemia has come under control, and it has been, I think, it has been practiced very well by the doctors, where anemia is tackled very well. Then, yeah, talking about the anemia, that iron is very important for the anemia, but iron, probably today we talk about the molecular biology, targeted therapy, where you talk about the cellular level. So iron is required for metabolism, energy for metabolism, DNA synthesis, cell cycle arrays, apoptosis, and hepcidin, the hormones, which is responsible for regulating the iron. These are the important factors. So iron become the most important factors in each and every cell, living cell. So we have got to know what is iron and how it is regulated and how it is important in our life. But today I'm going to talk about skin and hair, importance of iron in skin and hair. Of course, in skin there are epidermis and dermis and the stratum corneum, that is dead part of the skin. There are sub layers like stratum granulosum, spinosum, and the collagen tissue, elastic tissue. But role of iron with the epidermis, iron levels vary over the wide range. Sun exposed region may be associated with the higher level of the iron. Dermal iron levels also vary, and the aging may be associated with the higher level of iron. And iron containing proteins are required for the building up collagen metabolism. The collagen metabolism is very important, our skin structure. So that is how we need it. But before that, I thought I'll go for the physiology of the iron. You must have heard it and you know it. We are just revising. Where the intake should be about 10 to 20 milligram of iron every day. Once it is absorbed, is the iron is transport for both, one for the storing and one for the once it is stored, again is transported for the utility of the iron, that it is stored as a ferritin, myoglobin, and again this is used as a plasma transferrin to formation of RBC, which are formed in the bone marrow by the and the process of erythropoiesis starts the red cell production, again iron storage in the reticular endothelial cell. This is how the iron is stored and utilized. But today we are going to talk about the iron loss. Iron loss means iron, we are going to lose the iron from the body. The important part is urine, sweat, feces, discommission. Discommission, can you see this is a part of the skin? That is a keratin cells or stratum corneum, where we are going to lose the scales of the skin in the scale formation, and this discommission, we lose iron. And of course, menstruation, there are many, but today we are going to talk about the discommission. Before we talk about the discommission, I thought, let me show how the iron plays the roles. For example, it is useful to prevent the oxidative stress. For example, the fibroblasts, which are exposed to ultraviolet, can generate ROS, and that promotes oxidative damage in lysosomal, mitochondria, nuclear, plasma, and plasma membrane. So these are all part of the cell survival. Without that, we cannot survive. So iron is very important for each and every cell. I think. Now, when this iron deficiency patient comes to our clinic, either they come with the pelar, as any patient comes to our clinic, we are supposed to see their conjunctiva on the nails. Then, whenever there is an iron deficiency, patient complain of scratching or the itching, diffuse hair loss. Hair loss is very common. People who have got iron deficiency, Kylonukia about the nail, smooth tongues or what called ball tongue, and the glossitis. These are the symptoms. The patient comes with the symptoms, and we should look for the sign, and that will give idea about the iron deficiency. Then coming to a role of iron, iron is a potential therapeutic target in the skin. They are approved by the topical iron chelators and delayed cutaneous wound healing, that iron is required for the skin. Yeah, skin formation. Yeah, that is about the skin. That when there is a deficiency of iron, what about the skin? We mentioned. Now about the hair. Hair again, see what is the important part. The hair is the hair follicle matrix is the most rapidly dividing cells, and when they are dividing cells, they need iron. So that in any condition like alopecia areata, androgenic alopecia, telogen effluent, or diffuse hair loss, will find the iron deficiency. And this iron deficiency comes, or it prevents the rapidly dividing cells. This is how the hairs are also affected, like skin is affected. Then treatment. Coming to the treatment, all of us we know what is the treatment. That is primary prevention about the diet. Many times, the patient they do not take proper diet is very important. I'll give an example. I think I'm just adding my introduction. I'm practicing as a HIV clinician for 30 years. One of the pioneers is HIV, and many patients initially, I'm talking about 1992, they used to come with what we call is emaciated, thin, where there are diet deficiency. Of course, there are deficiency of many things, but one of the important was the iron deficiency, and most of the patient used to be poor patient. You know what we used to give? Chane ka dal and jaggery good. That was very effective. Many patients of mine, I never prescribe any tonic except this, and they used to do very well. Is easily available and easily accessible and affordable to everybody. And any patient comes to my clinic with emaciated, always we write chana ka dal, that is a protein, and jaggery. Then treating with the iron deficiency anemia or deficiency, you know that they need they need oral intake or sometimes parental also, and supplementation. So when we start iron therapy, the re-evaluation with the therapy is working or not, that we need it. So iron is, so that is when there are deficiency, but only not sometimes there is overload. And one of the well-known condition, you know, that hemochromatosis, where is deposition of iron in the liver, and patient going to hemochromatosis, and there is a liver failure. This is well-known condition. This can happen not only liver, but it get deposition other part of the tissue also, and you'll find the fibrosis. The tissue go into fibrosis. So overloading of iron is also not good. What he need is a balance level of iron. Then approach to the hair loss due to anemia. See, any patients now, I would like to bring to your notice or OPD. The clinical OPDs now, the patient coming to OPD are changing. Previously, used to get infection like scabies. We used to get like a scabies infection was very pyoderma, but now before that we used to get a lot of patient of STDs, but now it changed. Most of the patient they come to our OPD, either they are of acne, pigmentations, or hair loss. This is the major number of patients they come to our clinic, and the hair loss has become very common. Of course, there are many factors, or the multiple factors is a complex. There are many reasons, but one of them is low hemoglobin. Any patient comes to my clinic for the hair loss is a dictum. Their CBC and serum ferritin should be done if the patient affording serum ferritin or CBC for only the hemoglobin. So that's why, so you have to screening what he requires is the iron or hemoglobin, and to confirm we require ferritin, because ferritin concentration can be used for the confirmation of iron deficiency. But if the patient can't afford, at least you get the hemoglobin done in CBC. Then identify the cause of iron deficiency. You will be surprised in our clinic. Many patients they come for the hair loss. Among them, most of them are young people between 25 and 30. And among the young people, most of them are girls, and most of them, they are on diet. That is the major cause of hair loss or hair fall in our OPD. And when they go on diet, their diet is, they go to selective diet, they do not miss. Very few patients take the balanced diet, and they go into deficiency. One of them is a iron deficiency. So in your practice, any patient come with a hair loss, first find out the patient is on diet, because that is a common cause. And of course, you have to find out is there any iron deficiency. For that, we ask for the hemoglobin or ferritin. Several studies in the women have examined the relationship between the iron deficiency and the hair loss. There are many studies. Male and female patient present to the hair loss should be screened for, I already mentioned, iron deficiency should be treated. And while treating, what is important, when you are given oral therapy, you have to see that in after 3 to 4 weeks there should be increase of 2 gram per dl, and you must see every 6 week you should screen it till it comes to the normal. That's how you have to follow. But again, I'm repeating, any patients of skin with the exfoliation, I'm going to cover those conditions where there is exfoliation, damaged skin, cracked skin, dry skin, there is always loss of the iron. So these are the conditions which I'm going to show you where you have to look for iron deficiency. If you do not want to go for investigation, I think you can start iron therapy, but you have to monitor that there is no overloading of iron. That's very important. Just giving iron is not important. About the skin structure, I already mentioned about the skin structure. Then there are type of skins. It depends of type of skin according to the Western country, Asian countries, the black skin. There are various types of skin, but here types are not important. What is important is cracked skin. Many times you get a dry skin, and you will be surprised. One of the common cause of dry skin is dehydration. And you know what is the cause of? There are many causes, but many people, they do not take enough water. So simple solution to prevent the dehydration: ask them to take simple water. When they take simple water, always, sometimes they keep on drinking water so much. Many patients, they get overloaded with the water again. So many patients, they ask me how much water I should drink. I said simple parameter: watch your urine. The urine is colorless, water is enough. Somebody may need 1 liter, somebody may 2 liters, but your color of the urine is very important. There's a very simple parameter. Just don't keep on drinking water, other will get overloaded. About the skin function, we know that is the first line of defense, but we have to prevent dehydration. So, what are the causes of dry skin? There are many causes, and I'll show you in the next slide that some of the people keep on smoking large number of cigarettes, their skin becomes dry because the vitality goes down. There are skin condition: atopic dermatitis, ichthyosis, psoriasis, seborrheic dermatitis, drug reaction. There are many skin condition. In fact, now season is for the winter. In Bombay, we call it the winter. Many patients, they come to my clinic for the dry skin. And when they come for the dry skin, you will be surprised. In the Bombay, this winter is enough to make skin dry. Many patients, they go into this problem. So what you call is a winter dermatitis or dermatitis himalis, and is very common in the elderly patient. Nowadays we call anybody above 65 is an elderly patient. They come with dry skin and scaling. I'm going to show the picture. Then itching. There are certain conditions they're getting all over the body where the skin is get damaged. When the skin get damaged, there is exfoliation and they lose a lot of iron. Of course, no need of telling the comorbidity. Nowadays, we are aware common is diabetes, renal problems, because now patients are living more than 65 years, more than 70, but most of them are living with the comorbidities. Either they're on antihypertensive, they are on statin. Statin is another reason or another molecule gives dry skin, and many people above 65, they are on statin. So comorbidity and the drug. Dialysis, of course, kidney patients who are on the dialysis, vitality goes down, there are deficiency of many things. One of them is iron, because you are going to talk, and that's why skin becomes dry. A malignancy underlying, because of chemotherapy, underlying malignancy, skin get anorexia that continues. And of course, I am being a HIV clinician. Initially, we used to see the patient with the dry skin. I'm talking about 91, 92. But now, we must thank our government and the pharmaceuticals for availability of the HIV medicine and the pre-HIV medicine, antiretroviral therapy. Patients are living healthy life and hardly they come with a skin problem. But few patients who, because social stigma, they don't come forward, they don't go for HIV therapy, they come with this severe condition, and where dry skin is one of the conditions is seen in as a presenting symptoms of HIV. So there are many conditions you will get a dry skin. Then who are the people are likely to develop dry skin? As I mentioned, middle age and the older people. About the skin, they say the medium complex skin less likely, but to the winter season many medicine. One of them I mentioned about the statin. Then low outdoor temperature, that is the winter season, and vitamin or mineral deficiency can give rise to dry skin and exfoliation. So, what are the symptoms of a dry skin? Symptoms for the cracked skin, rough, tight skin, flaking, scaling, itching. Sometimes it become darker. And these are the symptoms that there is a dehydration and there is damage to the skin where there is a possibility of iron deficiency. See, look at this. This is the lady, she has exfoliation all over the body. We can see on this when they exfoliate, they lose lot of B complex, calcium, magnesium, iron. But here we are concerned of the iron. They lose iron so much. We have seen the patient sometimes they may need admission because hemoglobin goes down below 6 gram, and they need admissions for the immediate. They go into some other patient go even your cardiac failure. We have seen the patient go into cardiac failure because of this anemia. This is another condition called seborrheic dermatitis. Seborrheic dermatitis involves the whole scalp, chest, back, sometimes the hands, and you will see that because of exfoliation, you may get the iron deficiency anemia. Unfortunately, when this patient comes to our dermatologist colleague, they treat the condition like seborrheic dermatitis, exfoliative, but what because of HIV we have learned what we call is a comprehensive medicine. In HIV, you got to know all system, cardiac system, liver system, kidney system. Even I am a dermatologist. By doing postmortem and treating HIV patient, we have learned internal medicine. So any patient comes to your clinic, any patient comes to my clinic, we just don't talk about the disease. Of course, we come to the diagnosis of disease, treatment of disease, and always we tell all patients of mine three things are important. One is your diet. So we talk to them about the diet, lifestyle, and secondly, exercise. Many patients they live sedentary life. In exercise, many people say we go to gym. I said no. Good exercise is walking, running, cycling, swimming, skipping, or playing individual game like badminton, table tennis, or tennis. Not playing like a cricket where you go and stand, you hardly do any exercise compared to individual game. So always we insist. And the last one is a supplementary. There is a deficiency of mineral deficiency, iron deficiency, B complex deficiency. You have to cover. We have to give this. But many my colleagues, if you see their prescription, is a fungal infection, they write only antifungal. But that's not enough. We got to write all, and among them, you must have realized iron is very important factor. You have to cover the patient with the iron therapy. This another condition called psoriasis. They get exfoliation all over the what is called erythroderma. Even you see there are plaque psoriasis, but it is there for 2 years, 3 years. They lose a lot of proteins, so they get hypoproteinemia or low albumin, and many times they need transfusion of albumin also. Of course, and where there is no proteins, there is no what we call is the hemoglobin formation because you require both proteins and iron growth, both. These are another conditions, what you call, I mentioned about the erythroderma, cracked skin, cirrhosis. Cirrhosis is very common. Patient above 65, winter, atopic dermatitis, psoriasis, when they come to your clinic, just giving moisturizer is not enough. You have to cover them with, find out, many times you'll find there are iron deficiency, B complex deficiency, mineral deficiency. You got to cover this. Otherwise, only just moisturizer are not enough. Then coming to this, we were talking about the skin. Now coming to hair. Here you know the structure of the hair, but I'll go for the next slide, which is a very important, that you know what are the functions of the hair. What is important is what is the normal hair growth on our scalp. See, most of the 80 to 90% are anagen. Anagen is growing. This condition, anagen, is the full structure. Second is the telogen. Telogen is a falling off. See, hair follicles and the hair shaft are they're separated from each other. And third one is catagen, that is the resting phase where the hair follicles are going into shrinking. So these are the thing. And lastly, again, there is a regrowth. So these stages are very important. So anagen. So our hair on our scalp, 80 to 90% of anagen. So when we examine patient, we see what is the percent of telogen, catagen, anagen. Anagen goes down, then definitely there is some pathology. That is called trichoscan. Trichoscan is a very easy method, but usually leave it to dermatologist because it's a time consuming, and as a family practitioner you have to look about each and every condition. So do not bother of trichoscan, just go by your clinical examination. About the hair, too much hair is a problem. Too less hair is also problem. So hypertrichosis, hirsutism, these are the endocrine problem. But decreased hair, where what we call is the alopecia, loss of hair, is called alopecia. It may be scarring and non-scarring. I'll just give an example. Any patient come to your clinic. See, if you look at this slide, it looks very ferocious. And you look these slides, only patch is lost. But this condition is not dangerous. This is dangerous because if you see here, hair follicles have been infiltrated or they are destroyed. So getting hair here is difficult unless and you go for the hair transplant nowadays. Previously, hardly there was any solution. Now we do hair transplant. So it's called scarring alopecia. This looks, of course, very ferocious, but it is reversible because hair follicles are intact. What is called non-scarring alopecia. Then there are many causes of the androgenic alopecia, which is the common condition in our OPD. Telogen effluent that usually occur because of the underlying therapy like oncotherapy or underlying comorbidity, malignancy, or the patient is having fever for more than 2 weeks, 3 weeks, drug-induced thyroid disorder, alopecia areata. There are many conditions. But common condition is what is called male pattern alopecia or the female pattern alopecia. This is the male pattern, this is the female. Male pattern is always from frontoparietal receding, while female pattern is always in the parietal in the central part. And if you look here, the common cause of this hair loss is a crash diet. And what is the deficiency diet? Many, but one of them is the iron. Even if you look here, telogen effluent, that is loss of the hair, here you won't get any scarring. And if you see here, the hair which are remaining there, they are terminal hair, they are dark hair, they are not villous hair. And one of the common cause is iron deficiency. Of course, zinc deficiency, the common is iron deficiency. Of course, there are many conditions. One of them is thyroid condition, thyroid disorders. Yeah, they are rare conditions, but alopecia areata is sometimes they come with a repeated alopecia areata, where supplement of iron is very useful. This is scarring alopecia because the underlying condition. So most of the hair, when the patient comes with the hair, routinely we get the investigation done, and already I mentioned in investigation, you must do what is called is the iron, thyroid, blood sugar, CBC, urine, LFT, and serum creatine. But most important is CBC, ferritin, thyroid, and blood sugar. These are the other condition: trichotillomania, traction alopecia. These are the androgenic alopecia. Of course, these are the type of alopecia, which is not. This is the male pattern. Again, iron plays major role. Apart from minoxidil or mesotherapy. Now, these slides are kept specially for you. Okay, it is showing that this is the patient came to my clinic. We are about 8 doctors who are working in my clinic, because nowadays another message I wanted to give you, that time of individual practice is gone. You should have team practice is very useful in all aspect. It take about earning, for diagnostic purpose, less stress, you enjoy more, you relax more, and it's going according to me. We are about 8 doctors. We get help from each other, because it's not possible of one doctor keep the track of each and everything. Even I am being a dermatologist is very difficult, because dermatology there are many branches. Like one of the latest is dermographism, which is I'm not good. My junior doctor is better than me. So always one of the messages I would like to give, go for the team practice, and which is I'm advocating for last 20 years. When I realize it, I hope you people will get involved in that. So this patient came, you ask any dermatologist, they will say the male pattern alopecia. But he came with this type of this bunches of hair losing. Usually the female they come with this. Always female they come with the wrap in the paper and they come and show this. But this is the person they came. Then this cannot happen in the male pattern. Male pattern they lose hair in single or two three hairs at a time, not with a bunch of hair. So then if you see, we ask history. He had a COVID. So nowadays, any patient comes to your clinic, ask history of COVID. 90% of the patient who are suffered from COVID, they lose hair. But this is reversible, because it's called telogen effluvium, and it takes about 6 months to 2 years in some cases, but it is reversible. And because the vitality goes down, it causes multiple deficiency, including iron. So you give the tablet which containing iron and other vitamins. So this was not male pattern, this was a COVID. So I thought I'll give the common cause of hair loss and how we should treat. And I think I'll stop it here. Thank you. Thank you very much for patient listening. And now we'll open for the question. Yeah.
Thank you, sir. Excellent coverage, excellent explanation, not only about anemia, but also about skin disease in general. And one thing I've learned today is that anemia can cause skin disease, but skin disease can also cause anemia. Like you said, the dermis is a good source, a
Yes,
good storage area for iron. So
Yes.
anemia can cause skin disease. Skin disease can cause anemia. Both
Yes.
might coexist with each other, just like that, because anemia is common, skin disease is common, and both might confound each other. So, like Dr. Saple sir has taught, don't jump to a diagnosis. Think of other things as well. The last case was COVID. COVID is a differential or hair loss due to COVID. is a differential of androgenic alopecia as well. So keep your minds open. Sir, many questions coming up for you.
Oh, that's good.
And
Yeah.
of course, many people are greeting you. Dr. Monu Gurung, Dr. Yogesh Uplenchwar, all your students are sending you greetings. Dr. Dharmaraj Gauri Shankar Dharmaraj from Karnataka, he's saying thank you. And he says, sir, in a diabetic patient, how do I approach? In a non-diabetic patient, how do I approach? I am a general physician. Is there any difference in the way I should approach a person with hair loss if he or she has diabetes or doesn't have diabetes?
I think Dr. Sanjay will be real expert. But let me tell you, many times we interact with the diabetologists. I hold the webinar with them, and they said very simple things. Whenever the patient has got diabetes, unless and until you correct it, you cannot complete the treatment, because without correcting diabetes, the condition cannot be cured. So the first dictum will be, you control diabetes and then treat the condition, definitely it will be corrected. Without controlling diabetes, I don't think we can do it. There are many conditions. For example, some of the patients, they come with the balanoposthitis. Many patients, they come with the balanoposthitis. You treat with your whatever the treatment is available, but if you do not control diabetes, they cannot. So we have to control diabetes. That is, I think, first priority. Dr. Kalra, you must be knowing better than me. Yeah.
Sir, you are right. One simple word mnemonic that we follow is called lemon. So, if you have somebody with hair loss, first of all, lifestyle optimization, LEMON. How do you tell the patient? How do you counsel the patient? And how do you approach yourself? L would be for lifestyle. Lifestyle will also include local. For example, traction alopecia. So here in Punjab and Haryana, we have this concept of dastar bandi, where the young Sikh boys, they are given the turban to wear. If they are given a turban to wear at very young age, at 7, 8, 9 years, and their hair is pulled back very hard, very harshly, they can get alopecia. E would be for endocrine optimization. Dr. Saple sir has spoken about thyroid, but do remember gonads as well. Too much of testosterone will lead to issues in hair. Too little of testosterone will also lead to issues in hair. M would be for medical and metabolic. So, medical metabolic will include things like renal impairment, hepatic impairment, any other infection, diabetes. All these
Yeah.
have to be managed.
Yes, correct.
O would be for organisms. So sometimes infections can cause hair loss, local infections. And Dr. Saple sir has spoken about that. Maybe we will ask him to speak again. Tinea capitis can be an example. And N, the last one, that is what we are focusing on today, is nutritional. So if you remember what sir started with in the beginning, he said the first thing I ask about is an extreme diet, restricted diet, fat diet. People assume that earlier people used to assume that protein energy malnutrition is the only type of malnutrition. Then we realize that obesity is also malnutrition. But in their zeal to correct obesity, people end up creating a third type of malnutrition, which is known as hidden hunger. Hidden hunger means it's not obvious. Of course, your skin, your nails, your hair, they are screaming from the rooftop that we are malnourished, hair loss. But the hidden hunger is mineral deficiency, like iron and calcium, vitamin deficiency, like vitamin B12 and vitamin D, which are common in the country. And the third is electrolyte deficiency. If somebody has dehydration all the time, dry skin all the time, then also you will get in trouble. So this is the approach that Dr. Gauri Shankar is asking about, and diabetes will come as part of the lemon. It will not be separate. And
Yes, correct.
Dr. Sable just taught us that if somebody comes to you with melanoposthitis or pruritus vulvae, the first thing you will do, you will get a glucose done, apart from asking for history of STD. Sir, more
Dr. Sanjay, that reminds my teacher about the baldness. They said, we don't mind treating your baldness, but your baldness will go off, but you may become bald somewhere else if you
yes,
suppress testosterone.
yes. So one of the oral treatments that is given for androgenic alopecia is finasteride, which is actually an
Yeah.
anti-androgen.
Yes, correct.
Sir, Dr. Vilas Sonavane, again, one of your students asks, Sir, chemotherapy can cause anemia. Chemotherapy also causes hair loss in patients
Yes,
with cancer.
yes, correct.
It also causes darkening of skin. So, how can
Yes.
we help our patients? Any simple tips you can share with us, sir?
See, the chemotherapy, of course, the history will be there. That is enough to diagnose. And chemotherapy, whatever is happening, is reversible. Only question of time. And with the chemotherapy, of course, there is a deficiency, so you have to give supplements like iron, calcium, magnesium. You have to give because this is called telogen effluent. The meaning of telogen effluent, the life of the I showed the stage of anagen, telogen, and the anagens keep on growing for almost 3 months to 1 year. While in this chemotherapy, the life becomes short. Instead of three months to 1 year, the hair starts falling within 6 weeks, 2 weeks. They starts falling up prematurely. And when the chemotherapy stop, it is reversible. Only the question of time, but you have to give a supplementary in those patients. Same thing about the skin also. Skin also the damage is reversible, but many times they require moisturizers because the skin becomes dry, starts cracking, and the problem starts. Yeah.
Sir, greetings to you from Bhillai and Chhattisgarh, from Dr. Anshul Singhai, and also from Dr. Aditya Vardhan. And Dr. Gauri Shankar has a question. Sir, I am a general practitioner. Could you please tell me just one or two ointments and one or two tablets to give a patient who has chronic itching? The patient has diabetes. The patient is saying, I keep on itching throughout the body. There is no localizing factor and there is no sign. I am not able to see any skin lesion.
See, if the patient has got diabetes and has got itching, again you have to correct diabetes. But what is important, the diabetic patient usually they are on multi-pharmacy or the polypharmacy. So drug of choice will be belastin because it has got hardly any drug-drug interaction because the metabolism is not in the liver. So that antihistaminic can use it. As far as theory is concerned, but I was conducting one webinar with about 100 dermatologists. I asked them which antihistaminic you write because my favorite antihistaminic is hydroxyzine hydrochloride. Hydroxyzine hydrochloride, and that gives tremendous because it has got two actions. One is anxiolytic, anti-anxiety, and anti-itching. So usually I prefer that, and most of the dermatologists prefer that. But theory-wise, you can prescribe belastin because the drug-drug interaction about hydroxyzine hydrochloride hardly there are any studies. That is the antihistaminic I would like to give. And of course, depends upon the liver is involved, kidney is involved. Accordingly, you can give it or pregnancy. Then coming
Hydroxyzine
to
is
coming
a
to
very
the
safe
local.
drug, sir, actually, in diabetes. And
Yes,
in diabetes, now we have this concept that itching, pruritus, and in Hindi we call it sukhi kharish. Sukhi, the patient is telling you dry itch.
dry
Basically,
skin.
patient is telling you there is no local lesion. That can be an equivalent of microvascular disease. It can be an equivalent of neuropathy. It is just that the nerve fibers for nerve pain are different and the fibers for itching are slightly different. But if you have someone with itching, like the way Dr. Gauri Shankar is describing, you treat in the same way that you would treat microvascular disease. And hydroxyzine, 10 or 25 milligram at night, sometimes half tablet in the morning, is very good way of correcting the neuropathy and the anxiety and the itching, all three together. And the
Yeah,
cheapest products are available.
yeah,
Hmm.
yeah, Dr. Sanjay. Many times we do an microangiopathy. Microangiopathy is the yeah, yeah.
That is the pruritus is an equivalent of that.
Yes, correct, correct.
Hmm. Itching, sir, you were ointment you were going to tell us, sir.
Yeah, in the ointment, again the basic ointment, what they need is a moisturizer. And the moisturizer, Vaseline is a good moisturizer. Castor oil is a good moisturizer. Patient can't afford, they want to go, they go. But many times is a messy. So there are many moisturizers are available in the market, but more effective any moisturizer which contains what is this? Serum.
Salicylic acid.
Not salicylic, that will irritate.
Hydroxyurea.
No, sir, I forgot. I mean, now I'm approaching 75, so I get some block. Sorry for that. Yeah, so anyway, that moisture, but any moisturizer is enough. But only when you apply all of the body, we go for the lotion more than the cream because people prefer lotion. So any moisturizer you can give it. Yeah.
One question, sir, if you allow me to take. Sir, the answer is ceramide, what you were saying.
Ceramide, right? Correct. So ceramide, absolutely right. Absolutely right. Yeah.
Thank Mr. Anand Mohan. Mr. Anand is a
Oh,
young person.
they have helped me. Thank you, Anil. Yeah.
One question let me take. This is enalapril versus sacubitril valsartan in diabetes and heart failure. So if you want antihypertensive, then enalapril is a good economical drug to use, backed by evidence, quite economical. But if you want to treat both hypertension and heart failure, then certainly sacubitril valsartan is better. Remember that you cannot give sacubitril valsartan along with enalapril. You will choose only one. So if patient was on enalapril, you want to give treatment for heart failure, you want to optimize it, you will have to stop the enalapril and start valsartan after a couple of days. Another question is from Dr. Vinay Desai. Patient is B12 deficient. Normal levels will be on the lab, roughly something like 250 to 900. Treatment regimen, what I prefer is sublingual, once a week for few weeks and then once a month. And it will be lifelong because it is usually nutritional deficiency. Unless the patient changes the diet. Maybe earlier patient was on strict vegetarian diet, vegan diet, and now patient says I will start eating non-veg. Then it is a finite treatment. But this is nutritional, and you have to keep a close watch on the nutritional history as well. Sir, one question for you from Dr. Vinay Desai. In women having hair loss, is it enough for me just to do hemoglobin and peripheral blood film? Or should I do serum iron studies and ferritin in all the patients?
See, ferritin is to confirm the diagnosis, but what I mentioned, that depends on the age. Usually, the young girl comes, ask for the diet. That is very important. And as Dr. Sanjay said, their lifestyle, that's very important. And then the common cause of hair loss is iron deficiency anemia. Another next is thyroid, and of course third is diabetes. Sorry, the diabetes comes second and thyroid comes. So these are the three common causes. Of course there are many, but first is a diet, lifestyle, and get these three investigation done. You'll be able to cover almost your 80% of female patients coming with the hair loss.
So we remember the power of three, and like Sarah said, iron deficiency, diabetes, and hypothyroid. These are the three common reasons. Dr. Manjula reminds us, thank you, madam, that you can give uh, for itching in pregnancy, you can give tablet Udiliv, and that will help if the SGOTPT are high, if there is a liver dysfunction.
Yes,
But
correct.
if there is no liver dysfunction, then this tablet will not help. Then maybe hydroxyzine, like Sarah said, is a better option. Very safe.
Yeah, but Sanjay, levocetrin is the drug of choice in pregnancy. Levocetrizine compared to other. Yeah.
Right. So, point well taken, sir. Thank you. Levocetrizine would be drug of choice, and if it is liver dysfunction, then we are
Then
happily
it will
treating
be,
that.
yeah.
Dr. Anshul says biotin. Does biotin help in hair loss?
Of course, biotin is one of the main factor. In fact, there is a condition in a child, 1 year child, they come with the scaling over the scalp. Continuously, they apply some coconut oil, but that condition is mainly because of the biotin deficiency. If you give biotin, then that condition can be treated. So they come with the scaly lesions, very difficult to make out this a biotin deficiency. So most of the patient they come with the hair loss and skin condition. We add biotin to most of the patient without going for the level of biotin.
And Dr. Anshul says, sir, in your experience, have you used gabapentin cream or ointment, local therapy for neuropathic symptoms? Is this commonly used in dermatology? Gabapentin cream. In endocrinology, it is actually not used and not indicated because it is not backed by evidence. The oral formulation is backed by evidence, so you can use gabapentin or pregabalin. And many times you will see overlap between itching and neuropathy. So, if there is an overlap, you will treat the neuropathy or you will treat whatever the patient's concern is. What is the patient's main complaint? And if you are confused, hydroxyzin is a very good drug to fall back upon. If patient's history is such that you are not able to differentiate between neuropathy and simple pruritus. Sir, one
No,
more
but
question. This is
Sanjay, you're absolutely right. In post-herpetic neuralgia, they come with the pain and the itching. And
yes,
you start gabapentin, both things disappear.
both disappear.
So, yeah,
That's
yeah,
true.
because it's the nerve irritation more than
Yes,
the yes,
yes. It will be oral, but oral
yes,
gabapentin,
correct,
not
yes,
not topical,
yeah, yeah,
not topical.
oral, yeah.
Sir, one more question from Dr. Singh. This is acanthosis nigricans, local treatment of acanthosis, apart from the metabolic optimization.
See, metabolic syndrome patient when they come or acanthosis nigricans, usually you can diagnose very easily, but their problem is black color or the pigmentation on the back of the neck and the armpits and the groin. But as you said, you have to correct the metabolic problems about exercise, diet, or whatever the drug you give. But then salicylic acid pill is very good if there is a hyperkeratosis. That helps. And if there is no much hyperkeratosis, then we go no melon, that is a depigmenting peel, because we need the local action. And many patients we give glutathione, but I'm not that happy with the glutathione because you have to give at least 6 months to get the effect, and it's very expensive. So local, if there is hyperkeratosis, ointment containing 3% salicylic, there is no hyperkeratosis, then pill called no melon that works very well.
And sir, like you mentioned in the dermatology clinic, the diseases have changed. Earlier we had scabies, now we
Yeah.
have acne. So
Yes.
what about acanthosis, sir? How infrequent was it earlier and how frequent is it today?
At least in my clinic, we get minimum 3 patients every day, and any patient come of this acanthosis, always we treat as a metabolic syndrome. That's why I keep on telling the dermatologist, you have to go now beyond skin, because unfortunately our dermatology is directly after MBBS, not after general medicine. And I'm being the HIV clinician, I realize that they should not give MD registration without doing MD general medicine, because we have to be first general physician, then we should go for specialty there, because acanthosis nigricans metabolic syndrome, we have to see even nowadays psoriasis, lichen planus, most of the patient they come with, if you go for hypertension. See, Sanjay, in my clinic, we have got about 8 doctors. For the patient goes to one of the doctors, they will take blood pressure, everything like a blood pressure, pulse, everything. We go like a general physician, and that reveals lot of underlying condition. So it has to be taken as a, with the multiple organ involvement more than just treating the skin. Yeah.
That is right, sir. When I did my MBBS, it was about 35 years ago in Ludhiana. I still remember during my dermatology posting as third year student, our professor told us, see this patient of acanthosis nigricans. Now the next case will come 1 year later. So he said, you are so lucky to see acanthosis because we get it so rarely. It was like spotter in exam. And now
Yes.
we see tens of patients every day, like you are saying.
Yes, correct, absolutely right.
And now, actually, it is more difficult to diagnose tinea incognito and to diagnose scabies because they are rare.
Yes, correct, correct, absolutely right. That
We
reminds me, Sanjay, one of the dermatologists had come from Iran to my department, and we showed him case of scabies he could not diagnose. So our all residents they were laughing. He is the head of the department, not able to diagnose scabies. But in Iran, when they get scabies epidemic, what they do, they create a pool, then ask the patient to swim in the pool. for the scabies patient. So they said we hardly see any scabies. I have not seen for last 20 years, so I've forgotten. So if you have not seen, it's very difficult to diagnose.
We acknowledge the questions by Dr. Gauri Shankar Dharmaraj on erectile dysfunction testosterone. But, sir, this is more than a 1 hour topic, just talking about erectile dysfunction and talking about hypogonadism. So, please allow us to address this during a later episode of Diabetes Essentials. After 3 weeks, we will be starting Diabetes Essentials again and we will take this topic up. Sir, it has been great being with you. So many questions coming up. And what I have learned personally is that there is much more to the skin than we see superficially. So, skin health or skin disease is much more than skin deep. And I have also learned from you, sir, that it is a bi-directional relationship between nutrition and between skin. Nutritional deficiency will cause skin deficiency, and skin deficiency can cause nutritional deficiency.
Correct.
I have also learned from you, sir, that the importance of holistic medicine, being able to see the patient as a whole and not dividing the patient into different bits and pieces, separate for medicine, separate for dermatology.
Yes.
In fact, sir, this quote is from Rabindranath Tagore, and Tagore says, if you pluck the petals apart, the beauty of the flower is lost. And sir, we have learned from you today the beauty of medicine. You keep everything together, you treat the flower as one, as a single flower, and then you can maintain the beauty of all the men and women, all the boys and girls who come to you for treatment. Sir, we have doctors watching you from across the country, and everybody respects you as a teacher. Sir, any last comments that you would have, take home message for all of us?
I think again I'm repeating. Any patient comes to your clinic, always think as a patient as a comprehensive care, and spend some time with the patient, because many times you'll realize that from the history 80% of the time history gives the diagnosis. And when I go as an examiner, there are four examiners. Usually they ask, what part you would like to take? I said, I'll ask about the history more than signs and symptoms. You can take out treatment, but I will take the history part. So history part is for that. Doctor has to learn to give some time to the patient and listen to the patient. Definitely, you will get many diagnoses by just listening to the patient. That is my message to everybody.
Strong take home for us, sir, and we will try to live up to your expectations and try to come closer to your standards. So it is difficult to meet them, sir, but we will try our best. With this, I would like to thank you, sir, for being with us, and thanks to everybody for having joined this episode of Iron Talks. And we hand over back to Mr. Basu, our ever smiling host.
Sir, it's been a pleasure today because I personally have worked with Dr. Professor Kaple for years now, and I can tell you that if anyone, a person like me also, if anyone who works with Dr. Saple for even for one subject of skin, if he follows him for at least for 6 7 months, he will graduate. Not only he will also become postgraduate also, because he is such a simple and such a wonderful teacher that he not only explores the basics but also takes it to the advanced, and then he takes it to the global level as well, sir. That is the beauty of Dr. Sapre, sir. Number one. Number two, the beauty of Professor Sapre is that he practiced at expensive clinics and hospitals of Mumbai, but his heart lies with the masses. I have seen it today, as well as in my last 7 8 years association with him, that whatever he thinks from the practice from the masses, whether it is chana gur to hydroxyzine to fluconazole to the basic ART therapies. That is the beauty of a doctor, that he treats the disease not influenced by any pharmaceuticals or advancement of the pharmaceutical industry. That's the beauty of Professor Sapre. And third, Professor Sapre's beauty is that he is not confined to today's knowledge or peer knowledge in India. He is continuously updating every day by associating himself to the other updated countries and America and the lower countries also, where he continuously disseminating his knowledge. He is 24 by 7 available. He doesn't take fees if he gets a case which is interesting and failed by many doctors seen in across India, sir. Today also, if you SMS him, WhatsApp him the case, he gives his diagnosis within a second. Within a second, he doesn't believe in battery of investigations. That's the beauty of Professor Saple. So, sir, it has been wonderful to get Dr. Saple and Dr. Kalra discussing 1 hour with us skin hair conditions in our iron talks. I would request Professor Saple to be there in our 52 weeks essential journey with Dr. Sanjay because there are many things which we have discussed today in journeys where I will request Dr. Kalra to involve the expertise of skin expert of Dr. Saple in the days to come in our journey when we once again start with 52 weeks diabetes essentials. With this, I thank Dr. Saple as well as Dr. Sanjay Kalra. Jai Hind and good night.
Jai
Yeah,
Hind.
Basuji, one sentence I must say, Sanjay has moderated very well, very
Yes.
well. So thank you, Sanjay, for that.
Thank you, sir. आपका आशीर्वाद है, sir. Thank you. Jai Hind, sir.
Yeah, okay. Jai